Hello and welcome to this webinar on unpacking diabetes in the heart, and we're going to be talking about the latest on risk and management strategies. It's a very great pleasure to meet all 3,000 of you that have registered for this meeting tonight, and I know it's a very interesting topic and one in which there's been so much happening. But first I'd like to begin, because we're based in Australia here, to acknowledge country and pay my respects to our First Nations people, their elders, and any First Nations people that are joining this meeting, and particularly those from other countries around the world too. We have some partners, the World Heart Federation and the Australian Diabetes Society, that are helping the National Heart Foundation of Australia in arranging this meeting, and an outstanding group of panelists, Professor Rod Jackson from the University of Auckland, an epidemiologist who I'll introduce in a moment, Richard O'Brien from Melbourne, and Ingrid Hopper, also from Melbourne, both working in the fields of endocrinology and particularly diabetes, and Roy Rasselham, a general practitioner from Queensland, who's going to bring a very practical perspective to this discussion. So we know that diabetes is emerging as, if considered as a cardiovascular risk factor, the one which is on the worst trajectory, really. We've got rising rates around the world, particularly amongst disadvantaged people. It's becoming more and more important. And at the same time, we've had quite a revolution in the availability of therapies for diabetes, particularly type 2 diabetes, and we'll be discussing those a little bit later in the meeting. It's an important subject, one which is moving very quickly, and I think this meeting is very timely. And just as far as housekeeping is concerned, there are some audience questions will be very welcome as the meeting progresses, and you put your questions in the Q&A box. There is no point in raising your hand, we can't see you, so make sure your questions are in the Q&A box. We know from experience with these meetings there'll be far more questions than we can possibly answer during the meeting. We'll try and get back to you later, and we'll try and make sure that the ones that are most urgent to you are dealt with. But let me begin by introducing the very first speaker, Rod Jackson from the University of Auckland. Rod has been very influential in designing ways in which risk can be predicted in cardiovascular disease, and I know from the project that we're running at the moment, trying to update the 2012 absolute risk guideline in Australia, we've scoured the world, and really the best information available is coming from Rod and his team in New Zealand, and the prediction equations that they've developed. So it's great to have him along tonight. And I know it's a very important question he's going to address, is that we know that diabetes presents a degree of risk, but how within that very large diabetes cohort do we decide who do we have to focus on the most, who is at the highest risk? What are the factors that contribute to it? What are the differences between type 1 and type 2 diabetes as far as risk is concerned? And how can we prioritise management for those at the highest risk? So over to you, Rod, and I look forward to hearing your presentation.
Kia ora, and thank you for inviting me to this. I'm just going to share my screen. Okay, is that all? It's up there? You can see my screen. Great. So in just in 10 minutes, I've been asked to cover all of those things, but here's my topic: how to stratify cardiovascular risk within a diabetes cohort, who's at highest risk. So let me just move to the next slide. So I was given 3 questions. What are the factors that contribute to increased cardiovascular risk in diabetes? How does CVD risk differ between type 1 and type 2? And to provide some guidance on how to stratify risk and prioritize treatment to those at highest risk. Well, to answer this first question about the factors that contribute to CVD risk in diabetes, I want to take you to our large cohort study in Auckland, the PREDICT study, which we established back in 2002. And we gave approximately 1/3 of New Zealand general practitioners some software, which they integrated into their patient management systems. And this software was basically the Framingham Heart Study equation, which you've had in Australia, because that's what we had at the time. And so what we got GPs to do is to use the Framingham equation to assess risk in their patients. But every time they used it, we got a copy of the data. And this next slide shows you how this works. So I've just got a picture of a risk chart, but this was an electronic form that was integrated into the software. They filled it in, or in fact, the first thing that happened was that the software attempted to populate the risk chart with data from the medical record. They completed it, pressed a button, gave them the patient's risk a la Framingham, but we then got a copy of the data, and over the next 15 odd years, we linked it to hospitalizations and to deaths and to regional laboratory test results, to drug dispensing and several other databases using this number, this encrypted NHI. Every New Zealander has a unique number, and so we're able to link multiple data sets. So using these data, we created the first PREDICT equations based on 400,000 primary care patients without prior CVD, aged 30 to 74. These equations were published in The Lancet in 2018. And what I'm showing you here is an online version of the PREDICT calculator that you can go onto this website yourself and use it. But the key point for showing you the slide is it's got the standard Framingham risk factors: age, gender, smoking, diabetes, systolic blood pressure, total cholesterol, and HDL. But we added to the framing, we added ethnicity, we had a series of treatment variables, we had family history, we had atrial fibrillation, and we also had a deprivation factor, which is based on socioeconomic deprivation, a postcode factor. And to cut a long story short, we found that this equation, surprise, surprise, did a much, much better job at predicting risk of cardiovascular disease in New Zealand than the Framingham equation. A key point that I can't go into today just because of time is that the Framingham equation, the one that you're using in Australia, is overestimating risk by 50 to 100%. And the reason it's doing that is that the Framingham equation was generated in the 1970s and 1980s, and cardiovascular risk has fallen dramatically since then in the States, but also in Australia and also in New Zealand. So what about diabetes? Well, the reason I showed you this is that in this equation, in this our first equation, we had a yes-no diabetes variable. It was simply yes, no, and all else being equal, women with diabetes had about a 72% greater risk of a cardiovascular event than women without diabetes, and men it was about 75. So very similar. Approximately 75% increase in the risk of cardiovascular disease over and above all the other standard variables: age, gender, ethnicity, deprivation, blood pressure, lipids, atrial fibrillation, etc. Now, when we generated these equations, our clinical colleagues in New Zealand asked us, what about those extra variables that we know increase risk of cardiovascular disease in people with diabetes? So what we then did is we created a separate set of equations in the subset of 46,652 people with type 2 diabetes out of our 400,000 cohort. And this is also published in The Lancet a couple of years later. And to demonstrate the additional risk factors, that question I was asked, what actually adds to risk, cardiovascular risk in people with diabetes? Well, it's all of the same variables that predict risk in people without diabetes, but with a few added extras. And you can see them at the bottom of this slide, is that how long people have had diabetes is an important factor. The HbA1c is significant. ACR, urinary ACR is important, EGFR, whether they're taking oral hypoglycemics, and also whether they're taking insulin or not. So those factors, in addition to the standard factors, are what, based on this very large cohort, is associated with increased risk in diabetes. And I've shown you this slide in particular because this is another free equation. It's on the web, and down the bottom you see the URL. And what makes this different from the previous one I showed you, it's not quite as pretty, but this has the diabetes question built in. So if you complete this equation and you click no diabetes, you get the variables that I showed on the previous slide. If you click type 2, you get these additional variables. So the second question I was asked is, how does CVD risk differ between type 1 and type 2 diabetes? Well, unfortunately, we were unable to answer that with the predictors, because even though we had 400,000 people and 46,000 people with type 2 diabetes, the number of people with type 1 diabetes, about 10% of all people with diabetes in our cohort. It was an insufficient number to actually create a separate equation. So what I can share with you is that there is a UK study, the QRIS study, which has got a lot of other problems, but one problem it doesn't have is size. It has in the order of, I think, 8 or 16 minutes. It's a huge study, but it has lots of gaps. And the key finding relevant to the question is that in type 1 diabetes, the hazard ratio, this is in women, was 5.66 for type 1, and for type 2, it was 2.95. So there's clearly an increased risk of cardiovascular disease in type 1 over type 2. We don't know how much greater, because the Q-risk equation did not include those extra variables that I showed you on the previous slide. So I think the bottom line is there is an increased risk in type 1 diabetes over and above type 2 diabetes, but we just don't know how much it is once you take all of the variables that are in our equation into account. So the final question I was asked was about guidance, and I see I've got another 1 or 2 minutes. Guidance on how to stratify risk and prioritize management to those people with diabetes at highest risk. Well, I think the answer is pretty clear cut from our experience and elsewhere, that general practitioners need equations like this integrated into their patient management systems. I think there is no other way that a busy practitioner can identify patients at particularly high risk. And an equation like this is the ideal sort of equation that you should use if you have a patient with diabetes in front of you. Now, this one is just an online standalone version, but equations like this are integrated into most general practitioners' electronic health records in New Zealand. And it starts with the risk factors on a template. These are integrated. They then generate a 5-year risk, and they give you a risk trajectory over time, plus the kind of 100 smiley faces. And then what they also do is they give you management advice. So this is personalized management advice. So I think if you want to predict risk in a busy general practice, you need some sort of equation like this integrated into your software. Thank you very much.
Thank you very much, Rod. That was wonderful, and we look forward to having similar kind of programs embedded in our GP software in the next year or so as we revise the risk prediction equations for Australia. And the background information has been hugely important in that. So we're going to move on now to another hot area in diabetes, and that's the pharmacological therapies, and in particular their cardiovascular benefits. As you know, there's been a whole lot of new classes of drugs, some of them with better than expected results as far as cardiovascular protection is concerned. And Richard O'Brien is going to talk to that. Richard's got vast expertise and experience in this area. He's in private endocrinology practice, but he's also clinical dean at the University of Melbourne. And thank you very much, Richard, for taking over.
Thank you very much, Gary. I only do a little bit of private practice. I'm mostly university, but it's a pleasure to speak about this very exciting topic. It's an exciting time, I think, in diabetes. There's been some wonderful new drugs that have come in the last few years, which have really had significant cardiovascular benefits. And we've just heard from Rod that diabetes is, really quite a significant risk factor for cardiovascular disease. And it therefore is interesting to look at trials of intensive glucose control, because you might predict that if you really control glucose well, you'll reduce cardiovascular risk. Now, in fact, the trials have been really quite consistent, and it's both in type 1 and in type 2 diabetes, that although microvascular complications have been reduced, at least in the duration of the trial, and these trials have gone from between 5 and 10 years, we haven't seen reductions in cardiovascular risk or in mortality. Indeed, in one study, there was even a small increase in mortality. If we look at follow-up from these trials many years later, we find that at least in some of the cases, there was a reduction in cardiovascular disease, but it certainly doesn't seem to be the main thing to do, control blood glucose well, if we want to reduce cardiovascular events. We've got to look at other things. And if we look at the therapies that are available, insulin, for example, a wonderful study, the Origin trial, which was glargine insulin used right from diagnosis, in fact, even pre-diagnosis, or people with pre-diabetes in that trial, it failed to show any benefit in terms of cardiovascular events. The DPP-4 inhibitors, we're all very familiar with those and are widely used, also haven't shown any reductions in cardiovascular disease. And so it was with great excitement that this class of drugs, the SGLT2 inhibitors, came along. These are selective inhibitors of sodium glucose transporter in the kidney. The way they work is they cause increased loss of glucose in the urine. And it's a bit like reducing the spillway on a dam. If you lower the spillway, the level of the dam goes down. That's exactly what happens with these drugs in reducing blood glucose. We see reductions in HbA1c, we see some weight loss, and we also see some reductions in blood pressure. So promising things that might improve cardiovascular risk. And the way these drugs work, the glucose is filtered, and instead of being reabsorbed in the renal tubule, it's excreted. And we ended up with about, on average, around 80 grams of glucose going down the toilet in the urine. And that, of course, is calories going down the toilet. So there is some weight loss that is associated with these drugs. They're also sodium glucose transporters. So there are alterations in sodium metabolism, which probably have very important renal consequences. But the great excitement came from this trial called the EMPA-REG study, where it was the drug empagliflozin, patients with existing cardiovascular disease, so they were high-risk patients, randomized either to placebo or 2 different doses of empagliflozin. And there was a striking finding of a 38% reduction in cardiovascular death. And I think it's fair to say that everybody, including people involved in this study, were surprised by this result. It really was not expected. This was designed, as many of these trials are, as a safety study, but we saw this very significant benefit. Now, There have been other SGLT2 inhibitors that have been developed, and there's another one that's not in here, ertugliflozin. They have been superior to placebo in showing reductions in cardiovascular events. I think it's fair to say that the biggest effect for most of these agents has been a reduction in heart failure. I'm not going to talk about that because Ingrid's going to concentrate on that in the next talk. But really, it looks as if there are cardiovascular benefits of these drugs across the board. The cardiovascular death reductions seem to be very specific for empagliflozin, and so there is some question as to whether there might be some difference between the agents, and I think that is still something that's open to debate. As I said, all these trials showed reduced heart failure. What is the mechanism? Well, I think when you see a slide as complicated as this, you know that nobody is quite sure what the true underlying mechanism of cardiac protection is with these drugs. Lots of things have been proposed. We know there is a reduction in plasma volume and arterial stiffness. Interestingly, they increase ketones to some extent, and we know that they're a preferred substrate for cardiac myocytes, and there are likely to be many other things. It looks like there's some direct effects on cardiac myocytes that may cause benefits. So a lot of work to be done here, but really a very interesting class of drugs, and clearly the first thing that we've had that really benefits the heart as well as reduces glucose. And then the second group that's been very exciting is the drugs that work through the incretins. So incretin hormones, principally GLP-1 and GIP, are secreted by the gut when food hits it. They go into the portal circulation. They act on beta cells to release insulin and on alpha cells to suppress the secretion of glucagon. And the other thing they tend to do in the stomach, they slow gastric emptying, and there is effects on the brain, particularly with GIP, to cause appetite suppression. Now, the only problem is that this GLP-1 is degraded very rapidly by this enzyme DPP-4, and so long-acting analogues have been developed which are resistant to breakdown. And these agents are now available that can be injected once a week, and so we get very prolonged action of these drugs. And the exciting thing is that when you look at animal models, both GLP-1 and GIP do seem to have direct beneficial effects on the heart. And so, for instance, GLP-1 has been shown to significantly protect cardiac myocytes undergoing ischemia. So there was a suggestion that maybe increasing these hormones in the peripheral circulation, which is how these long-acting GLP-1 agonists work, might have cardioprotective properties. And indeed, for some of these agents, and these are some of the positive trials I've shown here, that was shown to be the case. So we had the first one, which was with liraglutide, the leader study. There was a 13% reduction in the major atherosclerotic cardiovascular events. We then had another trial, very short duration, only 2 years, a sustained 6 study with semaglutide showing a 23% reduction in events. And we've had one with dulaglutide, both of these bottom two can be taken once a week, showing a 12% reduction. That was both a primary and secondary prevention study, the others predominantly secondary prevention. So we've got some nice evidence that these GLP-1 analogues are significantly cardioprotective. Now, I mentioned there's probably direct effects on the vasculature, but there are certainly other beneficial effects with these drugs. They cause a reduction in body weight. With semaglutide, this is from the Sustain 6 study, was almost a 5 kilogram reduction and quite a substantial reduction in systolic blood pressure, 5.4 millimeters of mercury in the highest dose. They're also very good at reducing HbA1c, and you can see in this trial was 1.4 percentage point. Sometimes when they're compared with placebo, we can see reductions of over 2 percentage points in HbA1c, as well as these other benefits. And I think finally, because I'm just out of time, something even more exciting is coming, and that's a dual GLP-1 and GIP analog, where we are seeing very large reductions in HbA1c, up to 2.3%, and reductions in body weight that in some patients are greater than 20%, but in this trial, on average, 11.2 kilogram reduction in body weight. This is going to be available probably the first quarter of next year. It's just been approved in the US. We don't yet know the cardiovascular effects, but a meta-analysis of some smaller trials has suggested that it's very promising. So just in summary, SGLT2 inhibitors and GLP-1s have cardiovascular benefits, and this is unrelated to their glucose lowering. And I'm sorry I haven't had time to show you the evidence for that, but it's unrelated to their glucose lowering. They reduce blood pressure, they reduce body weight modestly, the SGLT2 inhibitors, and empagliflozin in particular reduce CV death. They also reduce hospitalization for heart failure. GLP-1s, some of them reduce cardiovascular benefits in randomized trials. They have large effects on HbA1c and weight and modest effects on blood pressure. And this new era, dual GLP-1 and GIP receptor analogues having big effects both on HbA1c and weight. And we look forward to their cardiovascular endpoint studies, which are going to be available soon. Thank you.
Thank you very much, Richard. That was a terrific summary, and you've certainly opened up the question that Ingrid is going to address in our next presentation in relation to these new drugs and heart failure, which, as you say, seems to be a special place for them. Ingrid is a clinical pharmacologist at Alfred Health in Melbourne, and has been deeply involved in studies of these new agents, and she's going to talk to us about the fourth pillar of heart failure management, how these diabetes medicines, or should we might talk in the discussion period about whether we should call them diabetes medicines, are used to treat heart failure. Thank you very much, Ingrid. You might be on mute.
My apologies. Can you hear me now?
Yep.
So I've been asked to review the landmark trials investigating the role of SGLT2 inhibitors for the management of heart failure, both heart failure with reduced ejection fraction and preserved ejection fraction, describe the role of SGLT2 inhibitors in the management of heart failure, and tips for prescribing. So there are three main trials I wanted to discuss today regarding the SGLT2 inhibitors in heart failure, and they include the DAPA-HF trial published in 2019, Emperor Reduced from 2020, and Emperor Preserved from 2021. So these trials compared dapagliflozin or empagliflozin at a dose of 10 milligrams compared to placebo, and they were quite large trials there. You can see the numbers, a number of multiple thousands. The primary endpoints were very similar. So for the DAPA-HF, it was worsening heart failure, which was considered to be hospitalization or urgent visit for IV diuretics or CV death, whereas the Emperor trials were both hospitalization for heart failure or CV death. The first two trials were a bit shorter, 18 months, whereas the Preserved trial went for 26 months. All patients needed to be symptomatic heart failure by virtue of the NYHA2 minimum criteria and have an elevated NT-proBNP in order to be included in the trial. The DAPA-HF trial and Emperor Reduced had patients with an ejection fraction of less than 40%, and the Emperor Preserved had greater than 40%. And it's worth remembering that according to current guidelines, patients with an ejection fraction of 40 to 50% are actually considered to be heart failure with reduced ejection fraction. The EGFR entry criteria for the DAPA-HF were greater than 30, whereas those for the Emperor were greater than 20. And most patients that were included in these trials were NYHA class 2, with a mean LV ejection fraction of 31% in DAPA-HF, a bit lower in the Reduced, Emperor Reduced at 27%, and Emperor Preserved was much higher, as you'd expect, at 54%. Up to 50% of the patients in these trials had diabetes, and they were very well treated in the background with high rates of beta blockers at up to 95%, 96%, RAS inhibitors, and also mineralocorticoid receptor antagonists, spironolactone or eplerenone. Those rates were a bit lower in the Emperor Preserved, with them, in particular the MRA, down at 37%. All three trials met their primary outcome for the primary endpoint, with about a 25% reduction in the endpoint of CV death and hospitalisation for heart failure. And although these trials were not powered to examine CV death or hospitalisation separately, it looks like these the outcomes were mainly driven by the reductions in heart failure hospitalisations. Across all three outcomes as well, there were benefits in renal outcomes. So what we saw initially when the medications were started was a dip in the EGFR across all three trials, which then improved, and over the long time there was preservation of renal function. So the possible mechanisms, which Richard talked about, I won't go into, but there are many mechanistic papers and we don't really understand what's going on, but we do know that it's independent, the effect is independent of diabetes and glycemic control, because both diabetic and non-diabetic patients were affected equally. There's a rapid onset of the effect of these medications, which is not explained by reduction in blood pressure, weight, or atherosclerosis. The benefit was seen within weeks. And there's the cardioprotective effect is thought to be in part due to improved ventricular loading conditions, so reduced preload and afterload, so essentially the diuretic effect, alternative cardiac energy sources through cardiac ketones, reduced cardiac injury, hypertrophy, fibrosis, which leads to improved remodeling and also improved endothelial function. So in summary, in symptomatic patients with heart failure, 50% of whom had diabetes, SGLT2 inhibitors were observed to reduce cardiovascular death and heart failure hospitalizations in patients across a broad range of ejection fraction, up to 60 to 65%. They reduce the risk of major adverse renal outcomes in patients with heart failure, and these effects are additive to the established drugs for heart failure. These medications confer their benefit early in the treatment within a few weeks, and is considered in the context of heart failure to be a class effect. The SGLT2 inhibitors have thus emerged as the fourth pillar of foundational therapy for heart failure. And we are now seeing a consensus recommendation that all these four drugs, so ARNIs, or if they're not able to be prescribed, ACE inhibitors, beta blockers, mineralocorticoid receptor antagonists, spironolactone and eplerenone, and SGLT2 inhibitors are considered to be the four medications that form the pillars of heart failure therapy. The sequence of how these medications are given has not been defined, but one of the good things to note about SGLT2 inhibitors is that there's no up titration requirement, as there are with all these other medications, so they're much easier to give. They're often easier to commence in patients where hypotension is a problem and you haven't been able to bring in any of the other medications. And it's really important to remember always that to commence a beta blocker in patients who are euvolemic, and SGLT2 inhibitors can in fact help the prescribing of a beta blocker and work against the fluid retention which occurs often on the commencement of beta blockers. SGLT2 inhibitors have also now got a guideline recommendation for heart failure with preserved ejection fraction, and we're expecting to see a new set of heart failure guidelines published in the MJA in the coming weeks. There's very limited experience with SGLT2 inhibitors in this condition, and in fact, only one medication, empagliflozin, has been shown to have this effect at this time. At the moment, it's TGA approved, but not PBS approved, and what we'll see over time is some more information coming out about that, so watch this space. So here are my prescribing tips for using SGLT2 inhibitors in heart failure. So the first thing to remember is that SGLT2 inhibitors are easier to prescribe than most heart failure drugs. The target dose is identical to the starting dose, and the SGLT2 inhibitors can reduce fluid retention when starting beta blockers. Prescribing tip number 2 is that patient counselling must be undertaken by the prescriber. Patients should be told about genitourinary infections, and thrush can occur, and that's due to the glycosuria, which occurs with these medications. So these are more common in females, particularly perimenopausal females, and patients should be advised around genital hygiene with washing and abundant rinsing rather than using antimicrobial soaps, and also the use of topical antifungal therapies as required. There is a slightly increased risk of UTI in some of the heart failure trials, and that needs to be watched for as well. Patients should also receive sick day counselling. So these medications are to be given for when patients are well, but if they're unwell, they should be withheld. And that's particularly if they end up in a prolonged fasting situation with gastroenteritis, for example. And there is a low risk of euglycemic diabetic acidosis. ketoacidosis. It's a severe side effect, so patients need to be warned about it. It's seen less in the non-diabetic patients. If fasting for surgery, there's a recommendation to stop these medications 3 days prior and to start when the patients are eating and drinking again. Prescribing tip number 3 is around the diuretic and renal effects. So the diuretic effect of SGLT2 inhibitors is around between 100 and 500 mils per day. And you can think about SGLT2 inhibitors as being equivalent to about 20 milligrams of Lasix. So if a patient is fluid overloaded, the diuretic effect can be, the diuresis can be enhanced by SGLT2 inhibitors. If they're euvulemic, you can consider reducing Lasix, and you do that by about 20 milligrams. And in certain patients, an increase in the fluid intake may be temporarily required. With regards to the EGFR dip seen in the renal slide, there's also the rise in creatinine. It's normal and it's reversible, and you should expect to see a rise in creatinine that peaks at around 4 weeks and then stabilizes. But if the rise is greater than 30%, it would be important to look for alternative causes before considering cessation of an SGLT2 inhibitor. Prescribing tip number 4 is to assess the risk of hypoglycemia in type 2 diabetes. So when you're prescribing these medications in diabetics, you should check their diabetes medications, in particular sulfonylurea or insulin, their EGFR, HbA1c, and episodes of hypoglycemia, either on self-monitoring or in history taking. If the patient is not on a sulfonylurea or an insulin, there's no risk of hypoglycemia and you're good to go. If the EGFR is less than 45 and the patient has heart failure and diabetes, the SGLT2 inhibitor has a glucose lowering effect which is lost, but the heart failure benefit continues. So you should continue with that medication. If the EGFR is greater than 60 and the patient's monitoring their own BSL, get them to continue to monitor their own BSL and reduce their medications accordingly if they run low. But if their EGFR is greater than 60 and their HbA1c is close to 7, it might be reasonable to proactively reduce the dose. And talking to an endocrinologist about complicated patients is always a good idea. So in summary, SGLT2 inhibitors in patients with symptomatic heart failure reduce cardiovascular death and heart failure hospitalizations across a broad range of ejection fraction, regardless of diabetes status, and it preserves renal function in heart failure. And SGLT2 inhibitors are now one of the 4 pillars of medication therapy for heart failure with reduced ejection fraction. They are also the only guideline recommended medication for heart failure with preserved ejection fraction. So watch this space. And the other thing to remember is, compared to the other heart failure medications, these are easy to prescribe, and we hope to see them used. Thank you very much.
Well, thank you very much, Ingrid, and thank you particularly for those practical points at the end. You managed to answer some of the questions the audience have already raised, particularly in relation to sick days and pre-operation protocols, which I think are really important points. Now, we're going to make the audience do some work now. We've got a poll and 2 questions, and we'd be very interested in your responses. So, Rohanna, if you put up the poll, you can see the 2 questions. What's the preferred second-line agent after metformin for diabetes, of course, type 2 diabetes? And the second question, what do you think is the most important thing to target in lowering cardiovascular risk in patients in people living with diabetes? Of course, they're all important, but where do you put your priorities? So hit the button, and we'll show your results in a few seconds. How are we going, Rohanna? Are we ready to show results yet? Do you have good response rate? Okay, I think you've convinced everybody, Ingrid, about the ease of use of the SGLT2 inhibitor, and people see lipids as being a very significant and important factor. You need to scroll that up to see that they haven't, as a group, we haven't put a particular priority on anything, perhaps glycemic control and blood pressure lowering, but all of these things are seen as being very important. So thank you. That's a very useful result. So we're going to move now to some questions, and I'm going to direct the first question to Roy Rasselin, because as I said, he's at the coalface in general practice. I'd be interested in your general reflections on these presentations. What do you take away for primary care, Roy? And where do you think we might be able to take advantage of all this new information to benefit our patients?
Thank you very much, Gary. I've got a couple of comments on each of the presentations we have had this evening. With Rod's presentation, I noted that the Q-risk study showed increased risk of cardiovascular disease in type 1 diabetes of 5.6 and in type 2, 2.9, which is very significant. And also the importance of risk equations as part of the armamentarium of the general practitioner in assessing risk for their patients. With Richard's presentation, I noticed that most of the oral tablets used in therapy and insulin have very good evidence for microvascular complication reduction. But the newer agents, in particular SGLT2 inhibitors and GLP-1 receptor agonists, show remarkable reductions in cardiovascular disease, with empagliflozin showing reduction in CV death, and SGLT2 inhibitors as a class showing reduced hospitalization for heart failure. And lastly, with Ingrid's presentation, I noted that there was good evidence for SGLT2 inhibitors in both forms of heart failure with reduced ejection fraction or preserved ejection fraction, and that it should be considered as the fourth pillar of heart failure treatment. So those are my initial comments, Gary.
Oh, thank you very much, Roy. That's good. So lots of great questions from the audience. So let's move to a few of these. While you're on the subject of type 1 and type 2, one from the audience is, can SGLT2 inhibitors be used for type 1 diabetes? Do they work as well, and are they still cardioprotective? There's probably one for you, Richard.
Well, Roy could answer this as well. Look, there have been trials in type 1, and certainly for reductions in HbA1c, they are efficacious. There haven't been any endpoint trials in terms of cardiovascular events, specifically in a type 1 population. We do see higher rates of diabetic ketoacidosis, so that is something of a concern. But you've heard from Ingrid that these drugs are very effective at preventing heart failure, and indeed have an indication for heart failure completely divorced from whether or not somebody's got diabetes. So I guess in a diabetic patient with type 1 diabetes who's got significant heart failure, I would be happy to use one, but I would be very much cautioning the patient to monitor glucose if they get sick, to check for ketones, and to do the various things that Ingrid has already mentioned, such as stop them before surgery, those sort of things. But yes, certainly efficacious, and there's no reason to suspect that the renal and heart effects would not be the same in somebody with type 1.
Great, thank you. Anything to add, Roy?
I think I'd just note that it's not PBS listed in Australia, at least for use in type 1. So I think if someone's considering to do it, please do it in consultation with an endocrinologist.
Yeah, I should say, I mean, it is PBS listed if it's a type 1 with significant heart failure with, I think, is that right? Is it PBS listed for heart failure yet, or only indicated?
So it's PBS listed for heart failure in reduced ejection fraction,
right,
but not yet for preserved, and that's why we don't have the experience.
Yeah. But
for PBS listing means reimbursement, and I think it's generally follows what happens in the rest of the world.
But Roy, I agree. You've got to be a little bit careful in that group.
Good advice. Look, one for Rod from a GP in New South Wales. Can you tell us more about the cardiovascular risk profile of people with pre-diabetes? Is that risk reversible, like their risk of diabetes?
Well, 2 points is that the risk in cardiovascular risk in people with pre-diabetes or indeed diabetes is hugely heterogeneous and highly dependent on all those other risk factors. So it's very difficult to talk about the profile of a group, indeed whether they're pre-diabetes or diabetes. One of the things that we've learnt in our studies is that there are some extremely low cardiovascular risk patients who are diagnosed with diabetes. If they're non-smokers, they have ideal lipids and low blood pressure, etc., and have only had diabetes for a short while. Where there are some patients with pre-diabetes who have much higher cardiovascular risk than people diagnosed with diabetes because they've got other risk factors. They're smokers, they've got their lipids and not as good, they've got high blood pressure. So I think my message is that we need to stop really thinking of even diabetes, no diabetes, pre-diabetes, no pre-diabetes. We need to think of each patient as having this multiple possible risk factors, all of which act synergistically to increase their cardiovascular risk. I mean, my ultimate is to get rid of the condition known as diabetes, because it's actually a continuum. I mean, we've pretty much got rid of hypertension as a construct in New Zealand. We treat risk rather than a blood pressure. On my wish list is to do the same with diabetes. And it's not to say that glucose is not extremely bad for your arteries, as indeed blood pressure is extremely bad for your arteries, but these are not dichotomous risk factors.
Thanks, Rod. They're fighting words. I want to explore that diabetes risk, though, if you'll allow me to call it that, a little bit further, because in your predict equation, people on glucose-lowering agents were at higher risk. People who are on insulin were at particularly higher risk. Of course, that was data taken at a time when these new agents weren't available, so we don't know what that would do to that kind of generic question. But I wonder if you could just explain that a little bit, and perhaps explain to our audience the differences between association and causality in this context.
Okay, so that's a very good point. In an equation, these are prediction equations. So the fact that being on insulin is associated with a substantial increase in risk compared to other people with diabetes who aren't on insulin, that's simply because people who are on insulin have more severe disease. and so it is really important that when you look at the predictors in these equations, they're not related to causation. Indeed, being on a blood pressure lowering drug is also associated with a substantially higher risk than not being on a blood pressure lowering medication. And that again is because the patients that we put on blood pressure lowering drugs have probably had sustained raised blood pressure for quite a long time. So yeah, this is not causation. Don't look at any of the variables in these equations as indicating causation. They're all about predicting the risk in our patients. So it's a very good point, Gary, that these do predict risk well, better than any other equations, but it's not about causation.
Thank you. A couple of questions related to working in hot environments or low resource settings. One's, do SGLT1, this is from a GP in central Queensland, have a particular effect on sodium levels? Because there are a lot of issues with that in the elderly in central Queensland with low sodium. And secondly, in low resource settings, because the GFR rise is expected and should reverse, do we really need to monitor creatinine and eGFR in an environment where resources are challenging? Perhaps Ingrid, you might like to tackle that first, but of course any of the panel can join in.
Yeah, so the sodium question is an interesting one. I haven't experienced any issues with sodium there, and certainly looking through the trials that wasn't monitored. I might ask Richard, have you had any experience in that area?
Yeah, they don't significantly affect serum sodium at all. I mean, the actual change in sodium reabsorption is tiny, but it has profound effects because it's the intrarenal changes that are really important. But it doesn't affect overall serum sodium, so which is pretty reassuring.
Thank you. And the other question, I think, is an excellent question. Should we be monitoring the renal function? And the answer is no. In fact, that's the advice that having used these medications for a couple of years now and getting quite anxious about the renal changes. And in fact, sometimes I even, in the early days, would stop the medications because of the creatinine rise and getting very uneasy. But what we've ended up doing is we just give the medications and we don't check. So if you have a patient with heart failure who is otherwise stable, start this medication. Don't even look for the first 4 weeks unless you've got a patient who's particularly low EGFR and frail, but start the medication and then come back to it later. Don't worry about it. The reason that you would be worried is when you are starting multiple medications. So that's the spironolactone, the ARNI as well. And that might make you a bit uneasy, as well as the SGLT2 inhibitors. And that's when you might look to do some monitoring, but keeping in the back of your mind that the renal function will improve over time.
Could I just say, I completely agree, Ingrid. For the GP in Central Queensland, just remember that these drugs do reduce plasma volume, and if you've got an older person in hot weather, they could get a bit hypotensive sometimes. If they're on other blood pressure agents, I know some of my GP colleagues will slightly reduce doses in the summer months, so that's just something to bear in mind.
Yeah,
Thank you.
If I could add, being from a tropical climate up where I am, most of our patients are very prone to dehydration as a baseline level, and we in fact have to tell them to take probably an extra litre of fluid intake in water per day to protect them from getting dehydrated.
So I wonder whether starting these medications in high summer would be a bad idea in those environments. Maybe keep it for an autumn or a spring.
Yes, look, having spent last week in London at 40 degrees, I think we need to redefine what a tropical environment is. But anyway, that's just an aside. We've had lots of questions from the audience on lipid management in people living with diabetes. Richard, how do you manage the typical lipid profile you see in
well, I think it goes on risk, first of all, and we can use Rod's equations now to work out who we should treat. And I was really pleased to hear Rod say that there are some people with diabetes who are at low risk, because I think it has been a fantasy that everybody with diabetes has the same risk as somebody who's had a previous myocardial infarction, and that's patently not true. But if you make the decision that a patient's at high risk, then statins are the first line. LDL is the primary target. The classic dyslipidemia, if you like, of diabetes is elevated triglycerides and low HDL, but every guideline around the world, because of such good evidence on LDL lowering, recommends that we start with LDL, aim for a reduction in a modest risk person of at least 30%, but ideally 50% if you can obtain that. And there are now new targets, I think, based on our knowledge of LDL and risk that's come from particularly studies with the PCSK9 injector, the very potent injectable agents. So somebody with a previous myocardial infarction and diabetes, very high risk, LDL of 1.4 as a target. For modest risk, a target of probably around 1.8 millimoles per litre. Really, atorvastatin and rosuvastatin are the only truly effective statins, and most of the guidelines would recommend that one of those be used now.
Good.
Thank you. Now, look, we've talked.
Sorry, could I just endorse that? I mean, if I was to start with any one drug, if you've decided the patient's at sufficiently high cardiovascular risk, the first drug I'd give is a statin, because it's the easiest to give, it's the most effective. I mean, of course, my standard approach would be think of all of their multiple risk factors and actually approach all of them in different ways, some with lifestyle, some with drugs. But if I was going to start with any one drug in a patient, I would give them a statin.
It wasn't very popular in the poll, but I agree totally, Rod. I think it's probably, if you only had one drug to reduce cardiovascular risk, it's the one that's going to do the most.
And it's the simplest with the fewest side effects overall, has the most effect on the risk factor as well.
Okay, well, we've talked a lot about drugs today, but of course, diabetes is driven to a large extent by lifestyle factors. And I think we've got a lot of questions. Our audience would like advice on what is the best nutrition advice to give people, physical activity, disadvantage came through in your predict equation, Rod. Where do we start or where do we finish with lifestyle advice for people with diabetes? Who wants to take that on? I'll offer that.
If I just start, there's no doubt that, I mean, the biggest driver of type 2 diabetes, aside from getting older, because age is actually the #1 risk factor, increasing age, but after that, overweight is way up there. So I'm not going to go, there are so many different approaches to addressing overweight, but there's absolutely no doubt that if you can reduce people's weight, you do reduce their blood glucose. You can reverse what we call diabetes if people significantly reduce their weight. And the way you reduce their weight is with a cardiac protective diet. So certainly not the high fat, low carb diet, which is full of saturated fats. It has to be, if you're going to go for a higher fat diet, it has to be the high monos and polyunsaturated fats. And with carbohydrates, not a low carbohydrate diet, but it's one with minimally processed carbohydrates. So kind of a cardiac protective diet that is also a weight reducing diet.
Yeah, just have a look at the Heart Foundation website if you want more detail on that.
Exactly.
Does anybody else want to add anything? We could talk for another hour, of course, on various aspects of lifestyle management, and we might indeed do that another time. But I think we need to close because we're out of time. Perhaps you join me in thanking our audience for, I think, what have been extraordinarily useful presentations and lots of good advice. Perhaps we could move on to give you some information on some of the new resources that are available that might just be helpful in your practice, particularly the Heart Health Check Toolkit, which is available from that website that you can see on your screen at the moment. That's got lots of templates that can be used on your patients. You can download them. It explains what is a heart health check, quality improvement tools that you can use, lots of good stuff there, and I would certainly recommend them to you. There's also available a simple lipid management resource, which makes at least one of those questions towards the end pretty easy, and again, that's available for download from the website. Next slide, please. We don't have any more slides, then in that case, it's for me to wrap up the meeting. I think we've covered a lot of ground. There's lots more available, as I've said, in other places. This recording will be available online for you if you wish to revisit it. And it'll be sent to you in the next few weeks. At the end of this session, there'll be a pop-up evaluation survey. And we'd be very grateful because, as you can see, these are very successful webinars and we want that to continue. So your advice is critical to that. If you want a completion certificate, it's available to download, but you've got to pay the price because it comes at the end of the survey. So well, let's finish now. And again, thank you all for participating, not just our panel, but also the team that have organised in the background that have organised the meeting. And finally, you, the audience, that really provide the zing to these meetings with the excellent questions that you've asked. I'm sorry we couldn't get through them all, but I think we covered some terrific ground. Thank you all.